doctor in sexual health and HIV from London in the UK, and I'm chair of the British HIV Association. Now, when someone says a speaker needs no introduction, rarely is it as true as it is for a speaker like Dr. Anthony Fauci. He has been director of the National Institute of Allergy and Infectious Disease since 1984 and at the forefront of the HIV response since. He has served under no fewer than 7 US presidents, some of whom, though decades apart, are strikingly similar. For Reagan and Trump, both celebrities who became presidents and presidents who denied or minimized the importance of major public health issues. The start of the HIV epidemic in the US under Reagan, of course, and some of President Trump's assertions related to COVID-19. But Dr. Fauci has been responsible for so many landmark achievements. The creation of PEPFAR under George W. Bush, which has been estimated to have saved millions of lives. Barack Obama's commitment to a national HIV strategy for the US in 2010, and most recently, the striking success in getting Trump to include eliminating new HIV transmissions in his 2019 State of the Union speech. Dr. Fauci is a celebrity, and whilst that celebrity may be entirely proportionate to his achievements, it is also one that must be an incredible burden to bear, though I can only imagine. He and other public health leaders who've had to make incredibly difficult decisions to protect populations during COVID-19 have faced unacceptable levels of attack and abuse. So Dr. Fauci, I would like to apologize on behalf of humanity and to thank you from the bottom of my heart for everything that you have done. Now, he's such a celebrity, I know of at least one person in this audience, Sebastian Poulan from here in Montreal, who is wearing his Fauci fan club socks, and I hope at least one other person is also. But as a celebrity, Dr. Fauci has been interviewed by many an illustrious publication. He's due to feature in a documentary, which will be airing in cinemas, no less, from spring next year. But my favorite of the interviews is this from the Washington Post, not least for the first line, as I too am someone who likes to swear a lot. And in fact, for the last several weeks, I've been telling everyone I know, and lots of people I don't, that I will be moderating Tony effing Fauci on stage at IAS. So before I actually swear, I shall stop and hand over to hear about HIV in 2022 and beyond from no less than Dr. Tony Fauci. Thank you very much.
Thank you very much. Thank you so much. Thank you so much, Laura, for that very kind introduction. It really gives me a great pleasure to be here with you at this meeting, albeit virtually in Montreal, to talk about something that is so important to all of us here and throughout the world, is the challenge of HIV this year and beyond. And I talk about it as seen on this first slide, as a view from NIAID, but it really is a view that touches upon all of us who have been devoted to addressing and ending this terrible plague. So we're here now in Montreal, and I could not help but reflect that 33 years ago, we were also here in Montreal, and I've had the opportunity, the pleasure and the pain for what we've been through of having attended essentially all of these international AIDS conferences from the very beginning, the first one in Atlanta. But if you go back to the 1989 June 5th International Congress, what was going on at that time? We were making incremental scientific advances. There was grim forecasts for the growth of the pandemic. However, there was a promise of newer drugs and their potential use in combination cocktails, although the triple combination that was transforming, led by the protease inhibitors in 1996, was not yet realized. But we were experimenting with 2 drugs at a time. I'm sure some members of the audience were there back then when we were doing that. We didn't have much progress in harm reduction, but AIDS activists, for the first time, began to attend meetings in large numbers. And in fact, at the Montreal conference in 1989 was the unveiling of a national AIDS treatment research agenda, a picture shown here of a very young Peter Staley, in which we became very aware of the important contribution of the activist community in bridging that gap which had existed before between input from those who are afflicted with a particular disease and who have an awful lot to contribute, as we've heard in the demonstration right here, which anteceded my comments. But look what's happened since then. If you look at the latest data, the 5th International AIDS Conference, shown there in 1989, there have been 84 million cumulative HIV infections since then. 75 million since 1989. That is something that is a daunting challenge that we now, although as I'm going to mention several times throughout my presentation, that we have got to get HIV/AIDS back on the forefront of the radar screen of the public health community at every single level, despite the fact that we are going through simultaneous outbreaks of a historic pandemic with COVID, as well as the emerging outbreak of monkeypox. The global HIV statistics, which Winnie unveiled just a couple of days ago, and I had the pleasure and the honor of being with her when she did that, albeit virtually, the numbers still are extraordinarily sobering. With 38 million people living with HIV, again, 1.5 million newly infected, completely unacceptable, 650,000 deaths. And as I mentioned a moment ago, since the start of the pandemic, 84 million infections and 40 million deaths. Now, throughout this talk, I'm going to be going back and forth with the positive and in some cases negative impact of the concomitant outbreaks of the continuity of a 40+ year outbreak of HIV, together now with the overlapping outbreak of 2.5 years of COVID-19. The negative impacts of COVID on the global HIV response are several, and here are just a few of the examples, some of which have been discussed at this meeting. Namely, diagnoses decreased and fewer HIV positive people started on effective ART in 40 of 50 countries in 2020. Harm reduction services for people who use drugs were disrupted in over 65% of 130 countries, and reduced access to TB diagnosis and treatment resulted in an increase in TB deaths among persons with HIV in 2020 compared to 2019. In the United States, one saw a decrease in HIV diagnosis, which one at first value might think would be a good thing. However, as we've seen throughout the world, this is likely due to disruptions in clinical care services, hesitancy in accessing healthcare, and shortages in materials because of supply chain problems for HIV tests during the COVID-19 pandemic. Okay, so now let's go to the theme of where we are today for this important meeting. It coincides very, very heavily and strongly with the National HIV/AIDS Strategy, which President Biden for the United States launched in December the 1st, 2021. And as shown here in a statement from the president, it's a plan to make sure that the latest advances in HIV prevention, diagnosis, and treatment are available regardless of the age, race, gender identity, sexual orientation, disability, or other factors. That is something that should be prevailing globally. And in that regard, with the global response, we are so pleased to now have John Ikenga-san as the new U.S. Global AIDS Coordinator for PEPFAR, as well as the joining now of PEPFAR and the Global Fund. And you all know the results of this have been transforming, but we must continue to support this at the highest level. With 21 million lives saved, 2.8 million uninfected children born to mothers with HIV through PEPFAR, 19 million people receiving ART, 1 million people newly enrolled on pre-exposure prophylaxis in 2021 alone, and 2.9 million adolescent girls and young women reached with comprehensive AIDS prevention services in 2021. In the United States, we have a plan for America of decreasing the HIV new infections by 75% in 5 years and 90% reduction in 10 years. I'm going to get to the implementation aspects of this in a moment. But the plan is really universal throughout the globe, which we all aspire for. Diagnose all people with HIV as early as possible. Treat rapidly and effectively to reach sustained viral suppression, and prevent new transmission by using proven interventions, particularly PrEP and syringe services programs, and respond quickly to new potential outbreaks to get needed prevention and treatment. Now, I'm going to get in a moment to the balance between implementation and new scientific discoveries, but right now, a very important element of achieving the goals of ending HIV, both in my own country but globally, is the implementation of existing interventions. And in that regard, in the United States, the NIH, and we also have sites globally, have supported implementation research of over 200 projects, and these have been outlined in a recent edition of the journal JAIDS. So here's where I want to go for the rest of the talk, is to go back and forth in understanding the two major pillars that are going to get us to where we want to go, and what you've heard in some of the discussion and demonstrations of truly ending the global HIV pandemic. One, importantly, is to close the implementation gaps. And the other, while we're doing that, simultaneously and in parallel, develop and deliver new, improved treatment and prevention interventions. So let's take a look at the concept of implementation gaps. The gaps that must be addressed immediately are testing, antiretroviral therapy, retention in care, the goal of viral suppression, the management of comorbidities, prevention and harm reduction services, food, housing, and security, human rights, including stigma and discrimination reduction. Although these are not purely scientific implementation goals, they are absolutely critical if we are going to end the outbreak. Now, what is it that we are going to implement regarding our scientific advances? We all know, and we've heard a bit about that with U equal U, and I'll get to that in a moment, that highly effective antiretroviral therapy, without a doubt, is one of the most important biomedical research advances of our era. We now have an ART medicine cabinet of a number of combination medications, which when we were doing this decades ago, there was a lot of complication to it, multiple pills, multiple times with different conditions. Now we have combinations that are given in a much more user-friendly fashion. And when you have that, it's all the more reason to make sure that that's available globally and with equity. Going back to the first individuals with HIV that I took care of in the summer and fall of 1981, when the diagnosis to the time of death was about 1 to 2 years at the most, because we were dealing with people who likely were infected for years and we didn't know it because we didn't have an etiologic agent, we didn't have a diagnostic test. Today, from a number of real-world evidence, we know that if people are put on in an expeditious manner, antiretroviral drug, that they could live, if they were in their early 20s, an average of around 56 years, giving them almost, not quite, but almost a normal lifespan. Now, if you look globally, the global AIDS deaths, as you can see with the red line, have declined dramatically as you have increase in ART coverage in the blue bars. And that's something that we must maintain that and not let it slip with the interruption of services that I mentioned associated with COVID-19. So when you talk about treatment gaps, what are some of the key challenges at the global level? It's initiation of treatment, adherence to therapy, and retention in care. Let's take a look at the initiation of therapy and the gap. I showed you the numbers a moment ago of 38 million people living with HIV. Although the very good news is that almost 29 million people are on therapy, there is still a treatment gap of almost 10 million people who could benefit today from antiretroviral therapy. Then there's the issue of adherence. These are statistics from the United States, but in many respects, there are variations of this throughout the world. If you look at the dark blue in the lower left, the optimal adherence, namely the percent of days covered, greater than 90%, is seen in less than 39% of people. Suboptimal but reasonable adherence, between 80 and less than 90%, is seen in about 19%. But look at the red slice of the pie, poor adherence, or the percent of days covered less than 80%, it is almost half of those in the United States, a developed nation. What about retention in treatment? And these are data from low and middle income countries. If day zero is 100% when someone goes on therapy, by the time you get to 48 months out, about 60% of the people are retained on treatment, something that we must absolutely improve on. Now let's move on to prevention. The toolkit that I showed you for treatment overlaps in many respects with the toolkit for prevention for any of a number of reasons. But rather than go through all of these, which I'm sure the audience is thoroughly familiar with, let's get to something that we know has now been scientifically nailed down as true, and you heard that in the demonstration. This concept has revolutionized HIV prevention, where treatment equals prevention. And we know that now because there was a lot of tension back then of what resources should be put in treatment versus prevention. The U equals U now is definitively been proven, and together with pre-exposure prophylaxis are the tools that we have and will need to implement to end this outbreak. A couple of years ago, about almost 3 years ago, my colleagues Bob Eisinger and Carl Diefenbach and I wrote a viewpoint in JAMA, which is at the time that I came out very forcefully for the concept of U equals U. And since that time, every organization that has looked at the data has agreed with us that, in fact, this is without a doubt an irrefutable concept that undetectable equals untransmissible. Now, moving on to other aspects of prevention. The FDA 10 years ago approved the first drug for reducing the risk of sexually acquired HIV infection with Truvada, which, although there was some concern about its efficacy early on, when it became clear and the confounding issues of adherence were straightened out, it became clear that those who used optimally and consistent use of pre-exposure prophylaxis, Truvada was about 99% effective in preventing sexual HIV acquisition. So we know that as a fact. But getting back between the balance of implementation and discovery, the cumulative number of global PrEP initiations, although it dramatically increased, as you see the increase in the height of the red bars, getting to where we are now with the blue bar at around 2.8 million, is the good news. But the sobering and somewhat distressing news is that the global need is measured in tens of millions, much more than what we are doing. Now, a discontinuation and suboptimal adherence and reinitiation of oral pre-exposure prophylaxis was recently reviewed this past spring. And again, more sobering news and an outcry for better implementation. Within 6 months of PrEP initiation, 41% of the users stopped taking it, and 38% had suboptimal adherence. We must do better than that. What's the second pillar of where we are in 2022 and beyond? And that is that we can, in parallel and simultaneously with implementing proven scientific advances, develop and deliver new, improved treatment and prevention interventions. So, what are the barriers to daily pill taking? I believe everyone who has had the opportunity and the privilege to care for persons with HIV know about this. It goes from substance abuse to insecurity in housing, to insecurity for proper diet, to mental illness, just outright understandable forgetfulness, stigma, pill fatigue, as well as other structural barriers. Now, just as I showed you the medicine cabinet when you were talking about the combination of drugs, we can improve on that. And the two ways that I want to discuss, among others, is long-acting formulations of antiretrovirals, as well as broadly neutralizing antibodies. So let's take a look at these truly important advances. The approval in our country and in other regulatory agencies of the extended release injectable long-acting cabotegravir and rilpivirine for HIV treatment. Now, be careful now, because I'm going to be talking first about these interventions for treatment and then show what we all know, how they can be aptly applied to prevention. So we know that about every 2 months, you can give an injection of a long-acting combination of drugs, and that, in fact, can continue to suppress viral replication. Abstracts at the recent CROI meeting showed that lenacapavir, which is a capsid inhibitor, when given twice yearly in treatment-experienced and treatment-naive patients, can actually suppress virus. The thought of that years ago would have been almost unimaginable, that with 2 injections a year, you could maintain this degree of suppression. Then there's monoclonal antibodies. Now, we know broadly neutralizing antibodies have now been used, and I'm going to outline very briefly for you this for treatment and prevention. We can get a person with HIV, clone their B cells, get broadly neutralizing antibody, and passively transfer it either for prevention or treatment of HIV infection. And it's based on the concept dating back to work done to develop an HIV vaccine. How vaccine work overlaps to help us with non-vaccine prevention and treatment, where a number of neutralizing epitopes, broadly neutralizing epitopes, have been precisely identified on the HIV envelope trimer. And antibodies have been developed against these. And we have any of a number of antibodies with the goal of every 6 months with long-acting mutationally modified antibodies to have perhaps the possibility of giving combinations every 6 months that could replace daily antiretroviral therapy. Now, the promise of combination therapy, it comes from a number of laboratories. Michel Nussenzweig has been a leader in this. I've had the opportunity to collaborate with him in my own lab about giving a monoclonal antibody and seeing that if you interrupt in a structured interruption and do a placebo-controlled trial, you can have an extended degree of suppression of virus replication. This is a first step in what will be a multi-step phenomenon with the possibility of having a sustained ART-free remission. Speaking of which, there's a lot of very important work continuing to go on truly a cure. And as I presented to similar audiences over the year, the pathways are twofold. One is a complete eradication, which is aspirational and really quite difficult. It has been done in unusual cases. We've heard about the example of stem cell transplantation, but the widespread applicability of this, although it is concept proving, still is very aspirational. But also, I think something more likely would be sustained virological remission. So now let's switch from advances in the treatment to go to prevention. As you can see in the yellow box, it's very similar because the long-acting ART for PrEP and broadly neutralizing antibodies can equally be used in the arena of prevention as it is in the arena of treatment. And that promise is twofold: antiretrovirals and broadly neutralizing antibodies. So let's take a look at the antiretrovirals. The same drugs, long-acting injectable cabotegravir, was actually shown to be superior to daily oral Truvada in preventing HIV infection. The first injectable treatment of cabotegravir extended release for pre-exposure prophylaxis reduced the risk of sexually acquired HIV. Now, right now, it's given every 2 months. The goal is to do it every 6 months or more. There are phase 3 trials that are evaluating, again, the lenacapavir for PrEP as opposed to just treatment. Again, there's 2 purposes. One, in 5,000 cisgender adolescent girls and young women in South Africa and Uganda. And then the second is 3,000 cisgender men, transgender women, transgender men, and gender non-binary in the US, South Africa, Peru, and Brazil. Again, I want to get back, as I talk about advances, to bring us back to the issue of implementation. Because as exciting as these advances are, we want to make sure that equity is a very important part of these advances. Moving on quickly to broadly neutralizing antibodies. Again, there have been a number of concept-proving trials. One, which is the HVTN 704 and 703, as well as the 081 and 085. We found that although there was not overall protection from the infusion of a broadly neutralizing antibody like VRC01, the efficacy against those viruses that was sensitive to the antibody was 75%, which is a very important proof of concept. Getting back to the slide I showed you before, now the positive aspect of each of these outbreaks on each other. For example, we know in COVID that Evusheld is a neutralizing antibody that is highly effective for 6 months in preventing the development of symptomatic COVID-19. So what we need to do for HIV is what we've been successful now with COVID: improve breath potency and durability, understand the serum levels that are needed for protection, that will help in vaccine development, understand the diversity of circulating strains and develop antibody combinations, have improved delivery systems, and as always, increase accessibility and affordability. Now, finally, in vaccine, the 4 decades of HIV vaccine development has been a very important journey that we have not yet reached the goal of what we want, but the scientific advances have been extraordinary. As you know, the virus isolated in 1983, an early stage clinical trial in 1987, and then a bunch of efficacy trials from 1998 on. Now, we have 24 years of HIV vaccine efficacy trial. I'm going to run through quickly a bunch of slides that show the titles of the papers associated with the trial. I'm going to go so quickly that I want you to look at the title of each slide because it gives you the bottom line. And that's the journey we've been through. At first, antibodies that bound but did not neutralize, we found out to our disappointment early on, do not protect. Then, classical CD8 T cell responses, in the absence of neutralizing antibody, do not protect. And in fact, activated T cells might actually have a deleterious impact as opposed to a positive effect. We had the Thai trial with a very modest 31% non-neutralizing antibody response. And the question is, can that protect in a high-risk population? And to our dismay, we found out the results were not repeated in population with a higher HIV incidence and prevalence. Add vector-based vaccines also did not induce neutralizing antibodies and did not protect. And as Carl Diefenbach and I summed all of this up in a paper about 2 years ago, that does not mean the end of the journey of a search for an HIV vaccine, because we must steadfastly move forward to address critical research gaps and unanswered questions. And although there are other approaches besides the neutralizing antibody approach, I want to get back to these neutralizing epitopes and in a very, very simplified manner, tell you the direction of where we're going. The question is to get the right immunogen that would engage the B cell lineage. We know from actually real world evidence that as the virus evolves in a person with HIV, and these are work originally from Bart Haynes and Michelle Nutzenzweig and others, you actually have the evolution of somatic hypermutation so that ultimately, after several iterations of the simultaneous evolution of the virus with the antibody, that you can get broadly neutralizing antibodies. Right now, in a very simple way, the studies are directed at doing that in the context of a vaccine. In other words, to engage the specific germline B cell. For example, with products such as the ODGT8 from the La Jolla group, or Emperor epitope from Haynes and colleagues, as well as others. I've just named 2 of the things that are going on. But the purpose is to sequentially stimulate the immune system in processes that are referred to as engagement of the B cell lineage, and then shaping and polishing, hopefully to ultimately get a broadly neutralizing antibody. So the question arises, in addition to that, can the rapid success with SARS-CoV-2 mRNA vaccine platforms be repeated with HIV? And as we know, a number of studies are going on now using that very exciting platform in an attempt to develop an HIV vaccine. So I'm going to go back to a slide here of a paper that my colleague Hillary Marston and I wrote several years ago. Now it's 7 years since we wrote that. It's been the theme of this particular conference, as well as every other IAS conference, is that it is very important to end this pandemic, that we must follow the science, to use the science as a tool and to be guided by the science. But getting back to the double theme of my talk today, I'll end with a reminder that these scientific advances absolutely must be implemented, but implemented with equity throughout the world. Thank you.
Fabulous, thank you so much. A characteristic tour de force as always. Now, we don't have as much time for questions as planned. I can't see any of the microphones as these lights dazzle through my varifocal glasses, so if anyone wants to ask a question, you might need to shout. But I have a few prepared. So my first one, Dr. Fauci, is if you could travel back in time to 1984, what is the one thing that you would do differently, reflecting on progress in the HIV epidemic?
Well, what I would have done, and I think we did it well, but I wish it would have been broader, was to more quickly engage in the real world setting the community. I believe I didn't get the opportunity to talk much about this, but particularly seeing the activists who are demonstrating today before the talk, the value of engaging community as early as one possibly can when you're dealing with a disease, not only is something that actually was extremely important when we did it, it is also relevant today. And we're seeing that with monkeypox, why it's so important to make sure that we hear in the real world setting. So, I mean, there are so many things when you look back, if you knew then what you knew now. I mean, there were things early on, you know, in 1984, we were just realizing we had a new virus. And I think you mentioned that, I believe, in your opening statement, Laura, that to use the bully pulpit of leadership in a country to alert the community to the danger of a particular emerging infection, that was not properly and adequately done at the time. And we know the reasons for that, and we need not go into it, but that's something you've got to do from the very beginning. When you have a danger signal, don't be afraid to call attention to that danger signal. And there was very big time danger signals back in 1984.
Thank you. Is anyone at a microphone? Yes, I can't quite see you, but I can see you waving.
Hi, I have a question. Joya Mukherjee from Partners in Health. Hi, Tony. Awesome talk. Thank you. I was really happy that I saw food security and housing security on your list of implementation gaps, but you did say they're not scientific. And I just wanted to ask you what you think is going to happen and how do we respond as a community to the increasing food insecurity in the aftermath of, or in the continuing COVID pandemic, and how we can not look at things like replenishment of the global fund, but actually expanding our social contract to really deal with the enormous vulnerability that we're going to continue to see among the most, marginalized people, and how that impacts all of the implementation we do? Thanks.
Thank you so much, Joy, for that question. But I want to make sure when I said not scientific, I meant not classic scientific experiment. The
I know
idea.
that. I'm yanking your chain.
I know you're yanking my chain, but go ahead. I don't mind. Coming from a friend, it's fine. But the thing that I really feel we need to do, and you sort of alluded to it in what you're saying, that if I had more time, I would have really emphasized that to me, it is unconscionable for us now because we are dealing with so many other challenges to slow down anything that we're doing with HIV. And in fact, we need to accelerate what we're doing with HIV. I mean, to me, that's the thing that I don't think people understand. And you know, dealing with simultaneously, as I do every day, with COVID, monkeypox, and HIV, you know, we can do all three at the same time. This idea about, you know, one competing with the other is understandable, but not acceptable. We've got to put all forces on all three at the same time. Remember, you know better than anybody on the non-HIV group that this is a 40-year pandemic. And this can't be a timeout. You don't call a timeout on a pandemic and say, come back next year. You've got to continue with all your might to continue to address it. And that's one of the things that saddened me when supply chain stopped, when testing stopped, when TB work stopped. That was really something that was very painful. We've got to get back on track. So thank you for bringing that up.
Hey, Tony. So David Miller with Health HIV. We know you got a lot of experience with mental illness while you were dealing with the Trump administration. But we've got millions of people with HIV who are developing HIV-associated neurological disorders. And we know there are limits to how we can get the drugs into the brain. And we know that that's a sanctuary region. We also know at the same time, we've got a crisis in nutrition, which exacerbates this in the developing world, like the South Bronx, where I'm from. So can you talk a little about how we could potentially start moving therapeutic vaccines for HIV and how we could emphasize clinical nutrition studies going forward?
Well, clinical nutrition studies, David, are obviously things that we really need to do. And in fact, one of the reasons that I'm a little bit optimistic now is that, and both of those areas, both, you know, I mean, therapeutic vaccines, we have tried with that. And I think the monoclonal antibody approach that I alluded to in my talk might give us better insight in how we can actually get a successful approach. Because if you know what actually blocks, then as you heard, I made a little side comment that the monoclonal antibody studies are going to give us a lot of good insight into vaccines, both therapeutic and preventive vaccines. But we have, for the first time last year, and it looks like this year, are going to actually get an increase in the HIV budget, which, as you know, was flat as a board for a number of years. So hopefully we can pursue some of the areas you're talking about, including some of the things that you mentioned, as well as what Joya mentioned.
Thank you.
This microphone.
Hi, Dr. Fauci. My name is Ryan. I'm from the Fred Hutchinson Cancer Center in Seattle, Washington. I'm a grad student. My question is, you've mentioned before in this session that you have overseen 3 pandemics now, AIDS, COVID, and now the monkeypox. And with each one of those, there seemed to be somewhat of erosion in trust in public health, largely amongst the LGBTQ community, as HIV and now monkeypox has disproportionately affected those communities. And so my question is, with your experience handling all of these 3 pandemics, One, how was it that the United States was completely unprepared for an emergency smallpox vaccine distribution? And how can we bolster trust in the public health institutions when, after COVID, we had 1 million Americans die, and now we're struggling to get smallpox vaccines out to people as monkeypox rapidly spreads? So how are we going to build trust and regain that trust in public health institutions as our public health institutions have largely failed us?
Yeah, well, as you probably know, if you know anything about me, I never pass the buck to somebody else. But when you say handle all 3 outbreaks, I didn't handle monkeypox. That's not an NIH thing. So let's make sure. And again, I don't mean to evade any responsibility, but when you look at monkeypox, what the NIH did do many years ago was help in the development of the TPOXX antiviral, as well as the MVA that now is Bavaria Nordic. What we have is a very complicated issue with monkeypox that we are hopefully catching up on now, where the original stockpiling on the part of Asper and Barter was really as a countermeasure against the terror attack from smallpox. And we have 100 million doses right available of ACAM 2000, which when Genios was developed, which is a much safer, particularly of people who might be immune compromised, as is often the case in persons living with HIV or at risk for HIV, the Genios doses were not for that group. They were for individuals who couldn't tolerate the ACAM, like people with eczema or people with immune compromise. The big surprise from an implementation standpoint was that the people who were most in need of the vaccine were persons either with HIV or at risk of HIV. And unfortunately, that was the group that needed not only post-exposure prophylaxis, but pre-exposure prophylaxis. So I am told that by the end of July, namely tomorrow and next week, that the 800,000 doses will be able to be implemented, superimposed upon the 300 and the 400,000. So we should have about 1.1 million. That's still not enough. We need to do better than that. Absolutely, because there are 1.1 million at risk, 1.6 million at risk. There are 2 doses of the vaccine. That means we need 3.2 million doses of vaccine. We would have liked to have had them available immediately, but unfortunately they weren't. But I think you're going to see a big change in that right now. Good question. I mean, there's no solid answer for that.
Peggy Johnston here, Tony. I think everyone here agrees that U equals U is a game changer. And for U equals U to be effective in stopping the spread of HIV, one has to know first and foremost that they're infected. So can you please address the testing gap and what will it take so that everyone who knows whether they're infected or not has access to cheap, rapid testing? And I ask that knowing that this is not within NIAID's mandate, but you're a thoughtful person and I'd appreciate your thinking on that.
Well, Peggy, thank you for the question. You and I have struggled with that when you were with me years ago, and we still don't have a good answer, except that the lack of real accessibility of health care and the stigma associated. I mean, I could speak for the United States, but it is probably, just an example of what's going on throughout the world. When you don't have accessibility to primary health care, and you have stigma associated either with your lifestyle or with the disease itself, it makes it very, very difficult to get equity and accessibility of that. So the only thing I think that we can do is that we've got to try everything we can to sort of change the complexion of how you think about HIV and how you think about those who are at the risk groups. I mean, I am very worried, as you might imagine, about what's going on in our own country, where you have attempts on the part of some to eliminate from payable insurance of affordable health, preventive services, which includes testing. I mean, if that happens, that will really be a disaster for the prevention, as well as you said, implementing U equals U. I don't have an easy answer for it. It's just a societal issue that's very disturbing. Sorry, Peggy.
Now, thank you very much. Now, we've actually already overrun by a couple of minutes. I'm sorry to the people at the microphones, but we are going to have to draw the conference to a close. We did lose some time for, of course, a very justifiable process. The fact those queues are so long, again, is a testament to the wondrousness that is Dr. Fauci. So I'm going to take chair's prerogative and ask one last question. Next time we're in the same city, can I buy you a beer?
Absolutely. Maybe two.
So thank you very much, everyone, for your engagement, your attention. This is a brilliantly attended session. And thank you again. I think a standing ovation for the man that is Dr. Tony Fauci. Thank you.